Good morning, my teachers, senior colleagues and colleagues. This morning I will answer question 12 of the National Postgraduate Medical College exams, November 2023. My name is Muhammad Sani Abubakar. Okay, the question is on teamwork and the question reads thus: a 92-year-old woman presented with complaints of lethargy, vomiting, and confusion. She had history of urinary tract infection and she was discharged 3 days ago from another hospital. History of osteoarthritis and fracture, which she had open reduction 1 year ago. The random blood sugar is 58 milligrams per DL, sodium of 130 millimoles per liter. Your friend, doctor, who is a senior registrar in geriatrics, came to the ward to see another patient and approached you to say hello. So these are the questions. The task, number one is, what are the problems of this patient? B, what teams will you involve in her management? C, what will you do when your friend came to say hello to you? So I will answer these questions this way. The first question, what are the problems? The number one problem in this patient is the age of the patient. The patient is 90-year-old. She's very elderly. Mostly they are fragile. They have their own peculiarities in terms of clinical presentation to diseases, response to treatment. This patient likely have some comorbidities. So this is the number one problem, and she required a specialized care, unlike other patients that are young. So the number one problem identified in this patient is the age of the patient. Then the other problems are the lethargy, confusion, and the vomiting the patient presented with. Then recent hospital admission is another very important problem because this patient was discharged 3 days ago and only for her to represent with lethargy, confusion, and vomiting. We don't know how long she has been having these symptoms, but we know that recent hospital admission is a risk factor for hospital-acquired infection. So looking at the background, the age, and this presentation, so recent hospital admission is a serious concern in this patient. Then this patient presented with hypoglycemia with random blood sugar of 130 millimoles per liter, and then had a history of chronic osteoarthritis and history of fracture, which was treated a year ago. Fracture at 91 is also a problem because this patient likely had a pathological fracture, and then so is another problem that need to be looked into. She may likely have poor wound healing and other things, and this may even make her to be bedridden. So it's another problem that has to look into. So these are the problems based on the available information on the question. So teams that will be involved include geriatrics. Geriatrics is number one team that will play a cardinal role in this patient, considering the age of the patient and the other unique features that I mentioned earlier. And then the other team that will also play a key role is the endocrinologist. Even though we don't have other history to suggest whether this patient is diabetic or the patient has been on oral anti-diabetic, but this patient presented with hypoglycemia. She may have other things, being an elderly, nutritional, well, they may have poor nutritional status. So, but it's important to involve endocrinologists in managing the hypoglycemia, not only managing, but also evaluating the patient to look at the likely cause of hypoglycemia. She may have other things. It may be a paraneoplastic manifestation. So, but so endocrinologist has to be involved. Other important teams that must be involved include the ID physician and microbiologist, because this patient had sepsis before. This symptoms she presented with could be a manifestation of septic encephalitis. So we have to, and also the previous hospital admission, this patient is likely to come down with a very multi-resistant organism. And looking at the patient, age and the likely comorbidities that may be on ground. So we have to involve infectious disease physician to properly manage this patient, also microbiologists that will guide in sample collection and choice of antibiotics. Neurologists may play a role here because even though we don't have other symptoms, but patient with this age may have other conditions like dementia, she may have Parkinson, who we don't know. And then this vomiting and lethargy could be from raised ICP, either from abscess, tumor, or anything. So neurologists may be involved in managing this patient. Of importance is nutritionists because this patient will require serious nutritional rehabilitation, considering the age and what is going on. So we have to involve the nutritionist, then nurses. This patient will require special nursing care, preferably geriatric nurses and pharmacists. Pharmacists will also play a vital role here because this patient is prone to polypharmacy. She may have a lot of likely drug-drug interactions, and she is likely to develop side effects to drug considering her age and the comorbidities that may exist. So we have to involve pharmacies in terms of drugs supply and also guide in drug administration and dosing. Then other teams that will be involved in this patient is the rheumatologists and orthopedic surgeons. This patient had chronic osteoarthritis. She had a previous fracture that was managed by open reduction, even though it was a year ago. But it's possible that being an elderly, she may have some complications from the surgery. So we have to, and also, so this unit may be involved in managing this patient. Then other units, depending on the detailed history, examinations, and other investigations may come in later in the course of care. And then family and caregivers have to be involved in managing this patient. So to a friend who is a senior registrar in geriatrics that came to me, it provides an ample opportunity for me to discuss the patient because being a friend reduces internal barriers to communication. And we know that the best form of information transfer occurs during face-to-face conversation. So I will discuss the patient with him. And then this provides opportunity for us to discuss the patient and to have his opinion and inputs into the initial management and even suggest other units that may be involved. And then he can relate the same information and findings based on our discussion to his consultants. Then I will formally involve his unit to participate in patient care, and I also clarify my role in the patient care to avoid confusion. So briefly, this is how I will answer the question. Let me briefly discuss the multidisciplinary patient care under this outline: introduction, team building, characteristics of effective team members, principles of team-based healthcare, benefit of effective teamwork, challenges to effective teamwork, practical tips to healthcare professionals, patient safety, and I will conclude. The core function of multidisciplinary team is to bring together a group of healthcare professionals from different fields in order to determine patients' treatment plan. It is a group of people with complementary skills, not the same skills, but various skills, knowledge, and expertise that they each contribute to work towards a common goal, a goal that they equally are committed to and for which they hold themselves mutually accountable. So what is a team? A team can be defined as a distinguishable set of two or more people who interact dynamically, interdependently, and adaptively towards a common and value goal, objective, or mission, who have been assigned specific roles or functions to perform, and who have limited lifespan of membership. A team can be taken as an acronym which stands for Together Everyone Achieve More. What of team-based healthcare? It is a provision of health services to individuals, families, and or their communities by at least two health providers who work collaboratively with patients and their caregivers to the extent preferred by each patient to accomplish shared goals within and across settings to achieve coordinated high quality of care. So an effective team is a team where team members, including the patients, communicate with each other, as well as merging their observations, expertise, and decision-making responsibilities to optimize patient care. So understanding a culture of workplace and its impact on team dynamics and functioning will make a team member a very good team player. So types of teams, we have different types of teams. Some are directly involved, some are not directly involved in patient care. So, but we have core teams. These core teams are the teams that are directly involved in patient care. Then the coordinating teams, then contingency teams. These are teams that are formed with specifically to manage emergencies like trauma team, cardiac arrest team, disaster response. Then other teams include ancillary team services. These are the group supporter services that facilitate patient care, such as cleaners, domestic staff, and then administrators who provides indirect task-specific services in healthcare facilities. And this includes secretaries, executive leadership of a unit or facility. So we need all these units to function effectively for excellent healthcare delivery. So it's important to discuss stages of team development. So these have shown that group needs to evolve through certain stages because of an effective, to become an effective team. In 1965, Bruce Stockman was the first to describe 4 stages. And these stages are as follows: forming, storming, norming, and performing. Forming this is the initial stage where people come together to form a team. It's typically characterized by ambiguity and confusion. Team members are trying to understand the fundamental questions of why am I here? Who are you? So it is important that the leader cast their vision, define the goal. This will answer the first question. And to answer the second question, the leader can create ways the team members know each other. So from after forming, this team will transform into forming stage. So at this stage, team members may come up with ideas and compete for consideration. In this stage, a defined problem solving process is introduced. It is a difficult stage when there may be conflict between team members and some rebellion against the task assigned. Task accomplishment is very low at this stage. There could be clarity of purpose, but uncertainties may continue. The next stage is norming. At this stage, the unit is becoming stabilized. Team members may show towards the leadership. Open communication between team members is established, and the team starts to control the tasks at hand. Generally accepted procedures and communication patterns are established at this stage. And then the performing stage is the stage when the team is fully stabilized. The team focuses on all or its attention towards achieving the goal, and the team is now close and supportive, open and trusting, resourceful, and very effective. So what are the characteristics of effective team members? Effective team members should have specialized knowledge and skills, should know their roles, should act collectively as a unit, and should possess specialized and complementary knowledge and skills, and should be able to take decision. These are the 5 personal values that characterize the most effective team members of high-functioning team in healthcare. Honesty is very important. There should be a discipline, creativity, humility, and curiosity. The principles that characterize a successful team-based healthcare include shared goals, clear roles of team members, effective leadership and communication, and measurable processes and outcomes. So what are the benefits of effective teamwork? The benefits could be organizational, team benefit, patient benefits, and also the team members. So virtually every sector benefits from effective teamwork. Organizational benefit includes reduced time and cost of hospitalization reducing unexpected admissions, services are better accessible to patients. To the team, there will be improved coordination of care, efficient use of healthcare services, enhanced communication and professional diversity. To the patients, there will be enhanced satisfaction with care, acceptance of treatment, improved health outcome and quality of care, and reduced medical errors. And to the team members, there will be enhanced job satisfaction, greater role clarity, and enhanced well-being. So several barriers exist to establishing and maintaining effective teamwork in health. And this includes changing roles, changing settings, health hierarchies in the healthcare, and individualistic nature of healthcare. Instability of things, it is because some of the things may not be stable, just like we discussed some of the types of teams. Some of the teams may just be transient, like a cardiac resuscitation team, let's say trauma team, So they may just play some roles at the initial stage. So sometimes they may allow some gaps in the health patient care. And then also another barrier is resolving disagreement and conflict. Practical tips for healthcare professionals should always introduce themselves to the team. You should not assume that everybody knows. You have to introduce yourself, clarify your role, use objective language to avoid confusion, learn and use people's names, be assertive, and state the obvious and avoid assumptions, ask questions, check and clarify, delegate tasks. If something doesn't make sense, find out the other person's opinion. Always do a team briefing. When in conflict, concentrate on what is right for the patient, not who is right or wrong. Okay, the main goal of multidisciplinary team care is to achieve patient satisfaction. A sensitive indicator of a successful health teamwork is patient satisfaction, which requires CPR, not cardiopulmonary resuscitation, but compassionate communication, patient information, and pain management and response. For a high patient satisfaction, it is critical to communicate to the patient.
We want to round up, please.
Okay, it is critical to communicate to the patient, encourage the patient, explain to the patient what you're doing. So in conclusion, the aim of multidisciplinary team care is to bring together a range of professionals to ensure a holistic social, medical, and psychological needs of a patient. And it requires an understanding of the characteristics of a successful team, knowledge of how teams function, and ways to maintain effective teams. These are my references. I welcome questions, comments, and contributions. Thank you for your time.
Yeah, thank you, Dr. Sani, for a very lucid presentation. So it's time for contributions, questions, and comments. You can raise your hand electronically, or you can type in the chat box. The class is open for contributions, please.
Hello, good morning, sir. Good morning.
Okay, good morning.
I couldn't find the space, the point where I can raise my hand, but I have some comments to make.
Okay, you can go ahead.
Okay, thank you. Thank you so much, Dr. Sani, for a very good presentation. I, however, have some few comments to make. You have actually done well. Although I missed the question, but I joined when you were answering the questions. But based on the available information that I was able to get, I can say that the few things I understand from the list of the problems, maybe you may need to add hypoglycemia as a problem list. Also, if you add frailty, being anemia or morbidity, that may not be out of hand. The simple way that you can know that this patient has frailty is by asking of what we call activities of daily living. Is she able to take bath herself, to feed herself? Is she able to walk, move, maybe say from bed to chair? So these are possible problems that, frailty is a thing that you may add as a problem list. Then regarding the professionals that will provide care for the woman, you may need to add a physiotherapist because, it's an elderly that had fracture. Most likely she may have been immobilized for a long time. So physiotherapist will have a role. Additionally, occupational therapists may also have a role where they can provide home care modification to suit the need of the older woman. You may also want to invite a social worker in which they may provide appropriate settings in which the patient can thrive at home, probably by advising on finances, by giving advice on the carers that may help in supporting the care of the woman. And okay, I think that's all about my comment. Thank you so much.
Okay, thank you very much, Dr. Shamsuddin, for
Thank you so much.
a wonderful
Thank you so much.
contribution. Any other comments or contributions?
Please, participants, comment, contributions. I want to appreciate the first speaker. Please, more comments and contributions.
Dr. Shamsuddin Yusuf, please mute your mic. Sorry.
If there are no comments, I don't know. Dr. Fatima, do you want to add anything since this was the exam?
Yes, good morning.
Good
Good morning, Ma. Good morning, all participants. Thank you very much, Dr. Sani. It's an excellent presentation. The presenter has done very well. This is actually a geriatrics case, which was given teamwork to set a question on that teamwork. So I think he has done very well. I don't have much issues with his presentation, but my advice to the participants is to go and read the lecture on geriatrics medicine. It was, I think, 2 comprehensive lectures were given in the update. So you need to go through it. You must be very sound in geriatrics as well as teamwork. It's not all about the teamwork, but even the geriatrics stuff, you need to know it very well. Because as you are answering, whoever you say you will involve as the team member, you will be asked reason why. If you say you'll involve a geriatric nurse, whoever you will involve, just as he rightly answered, you must mention their rules. So it's very, very important to go and read the lectures on geriatrics. Yeah, thank you.
Thank you,
Thank you very much for your contribution.
Good morning, Dr. Christabel. Good morning, Dr. Fatima, everyone in the house. I just wanted to point out something. This patient has had falls in the past. She's old. She has an ETI. Another thing we should dabble into is perhaps elderly neglect. And thus you need to perhaps bring in people to help with that as well. So that's where the help of the social worker, and of course, you may also need to bring in a psychologist, okay, not just for the patient, but even for the caregiver, because it's possible that the caregivers are burnt out and they started neglecting the mama as well. So, generally, when you see cases of fall or infection, you perhaps have to consider the possibility of elderly neglect. So, I just wanted to put that there. Thank you.
Okay, thank you, sir, for the contribution, sir. I don't know, Dr. Olabisi, is he in class?
Hello,
I don't think
Doctor.
he's in
After please,
class.
let's
So
share the question.
probably,
Let's share the question and attempt it in class.
okay. So I dropped a screenshot on the group. Somebody should help us share so that we can read it out and then answer it in class. Okay, okay, I'll read out the question, and we need volunteers also to attempt the question, especially participants that are going for these exams. So question 6 of the West African College of Physicians, the last exam, goes this way. Skin eruption of a 25-year-old female university student was afraid she had sexual contact with someone suspected to having HIV infection. She went to a pharmacist and demanded a post-exposure prophylaxis. She was given trizivir, the AZT, 3TC, MVP, that's nevirapine, which she took for 1 month. She presented with skin rash shown above with no mucosal involvement. The number 1 question is describe the skin lesion and stage the reaction. 2, what other findings will you look for? 3, what is wrong with the drug combination and how should the patient concern have been addressed? Fourth question is list the investigation you do for the patient, and then fifth question is what would be your approach in treating this patient?
Dr. Pick someone.
Okay. Attempt the question. Hello? Hello, can you hear me?
We can hear you, please. Oh, time is going.
Okay. Yes, I said, Dr. Itsubi, can you help us out here? If you can hear me.
Doctor, I can hear you, but I'm driving, please.
Okay.
It should be, that's not an excuse. Oh, no, it's not encouragement like this. Most of our facilitators are driving when we speak, when we teach. Please, attend the question, please. Please. If somebody can read the question out for you, then you attend it. Please, we encourage active participation. This is our thing. This thing can be handled by just few persons in this class.
Do I read the question again?
After I can read out the questions for him so that he will.
Okay, a 25-year-old female university student was afraid she had sexual contact with someone suspected to having HIV infection. She went to a pharmacist and demanded a PEP. She was given Trizivir, that's AZT, Nevirapine, which she took for 1 month. 1 week after starting the drug, she presented with skin rash shown above with no mucosa involvement. The questions that follow are: describe the skin lesions and stage the reaction. What other findings would you look for? What is wrong with the drug combination, and how should the patient concern have been addressed? List the investigations you would do for the patient. What would be your approach in treating the patient?
Yeah, there's Dr. Are you on the call?
Hello, ma'am.
Hello, sir. Are you on the call? Just
I
ask
am,
them
ma'am.
the question. What did you ask?
I would have loved to, ma'am, but well, I can't. I'm not able to now, ma'am.
You are not able to what?
I'm just listening in. I'm unable to.
I can't hear you clearly anymore. What did you say, sir? Dr. Asa, please speak to another
The
person.
patient has a skin, this is a likely drug reaction from the nevirapine combination this patient is on. Patient is on nevirapine, zidovudine, lamivudine combination.
Hello, Dr. Atta. I don't know if I can attempt.
Okay, you can go ahead. I think we've lost the 2B, so you can go ahead.
Okay. Good morning to our teachers. Thank you very much for the opportunity. Okay. I can't see the skin reaction very well, but going by the question, I can barely see the skin lesions. I'm not sure I can describe that. The picture is so much fading out. Okay, but zooming it in now, maybe I can just say some skin elevation around the arm, some skin lesions, rounded, circumscribed, but I can't really describe these lesions well. So I'll move to the other questions because I can't say it well. Let's take the reaction. Maybe I think it will be a drug reaction, most likely maybe as a result of what we call nevirapine rash, which is very common when patients are taking this combination. So I think this is a nevirapine rash, and the stage of the reaction, I will be going with stage 1, in which there is reaction, hypersensitivity reaction to medications is also part of it. And then what other findings will I look for in this patient? Well, I will look at other part of the body, whether there are any other things or any other rash in any other place. Apart from that, what will I look for again? Because of the combination too, it's good to be sure of the liver function of the patient, and then also whether the patient is pale or is not pale. This will also help in going ahead in taking care of the patient. What is wrong with the drug combination, and how should the patient concern have been addressed? Well, I'm not too sure of that, so let me leave that one for other members of the class to attempt. This is the investigations you will do for the patient. I want to do a liver function test. I will also want to do a full blood count plus differentials to look at the PCV. Also, it's good to do a chest X-ray and A&U creatinine for this patient. Other tests that will be useful is to do viral screening for the patient. ELISA test will be very important for the patient. What will be your approach to treating the patient? I will leave that one for the members of the class to attempt. Thank you very much for the opportunity to attempt the question.
Yeah, thank you, Dr. Temi, for attempting to answer the question. Is there any other person with any contribution to?
Dr. Ola Sekon, I believe I pronounce it well. He said something in the chat, but I must appreciate the last speaker. When we ask you to make attempt, we are not asking you to answer everything. Answer as much as you can. If you are facing the exam with this question, what will you do? The exam, you need to have a fighting spirit to pass this exam. You can't just, oh, I'm not feeling so well. Oh, I'm not feeling so good. Oh, my head is doing me one way. This exam is not like that. So if this is the attitude you carry from this class, the same attitude you carry into the exam, it's a fighting thing. If they give you a question, just attempt. Look at the last speaker. She didn't answer the question, but it's a fair attempt. It's a discussion. If she answer like 50%, someone else answer 20%, someone else answer 30%, all you know, 100% is complete. Well, it's a discussion. So we're not telling you, give us perfect answers. Just make attempt. So I must appreciate the last speaker. We've answered this question before. We've answered it before. So So please, more contributions, please. Doctor, there's somebody that made a comment in the box about the diagnosis. So please, you should speak up.
Hello?
Yes.
Hello? Good morning. Good morning, ma. Good morning, all. Okay, I just want to say one or two things about the diagnosis. So, looking at nevirapine, it has a tendency of giving Steven Johnson syndrome. Or a worst case scenario, it could be thin, depending on the percentage involvement of the skin. And what other findings that I will look up for in the patient is I will look at the mouth and the vagina, because if there is Steven Johnson, there may be involvement of the vagina mucosa and the mouth, because mucous membrane is involved in Steven Johnson syndrome.
Dr. Gopi, are you done?
Hello, can I be heard, please?
We lost you at a time, so we thought you were done. We can hear you now.
Okay, yes, I said there could be involvement of the mucous membrane, so I would like to examine the mouth of the patient and the vagina mucosa of the patient.
Okay, that's wonderful. Okay. So can you make some more comments on the investigations? And how will you approach the patient? That D&E, the first speaker didn't she was a fair attempt. Can you just elaborate a little on it?
It's like we lost Godia. But again, if we say, okay, Dr. Tanimu. Dr. Tanimu.
Thank you. Thank you very much for this attempt, and also it's a very good contribution by other people. But I think this one is post-exposure prophylaxis for HIV. In that regard, there are some drugs that are known to be used for post-exposure prophylaxis, and also drug combination in treatment of HIV infection or expected infection. In this case, they use Truvada for post-exposure prophylaxis, combination of tenofovir and emtricitabine. So this is the drug I think they use for post-exposure prophylaxis, not zadovudine, lamivudine, and tenofovir, and nevirapine. They said that for health workers who has accidental exposure, they can use 3 drugs, but for normal people or for other people, it's 2 drugs called Truvada. Truvada is a combination of tenofovir, diproxil, and the emtricitabine. So that is it. And the 3 combinations are currently now, the zadovudine is now not part of the regimen for HIV. It's now removed, I think, from the drugs because of its side effect. So, and also there are also some caveats in the use of in the combination of drugs for HIV infection, even among the same class. You cannot combine 2 adenosine analog into as a combination, but because you cannot combine tenofovir, like example now, you cannot combine tenofovir and didanosine. There are also the 2 drugs are adenosine analog. So based on that, I'm just giving example before I approach that combination also. Based on that, though they are all nucleoside reverse transcriptase inhibitors, but they are adenosine analog. So they may share the same side effect profile, and also they may share what? They may share drug resistance. So also lamivudine and emtricitabine, you can't combine them. So zidovudine and lamivudine combination have low effectiveness also. And also they are not the line of treatment in post-exposure prophylaxis. So I think that is why the drug combination are not, because they are not part of the post-exposure prophylaxis. They are not a good combination for the treatment of the patient. So that is it. So I think this is my one of my contributions. And also the skin rashes appear to be what? Complaint maculopapular rashes, mostly involving, they can be generalized because I saw that even the neck is involved. Erythematous, complaint maculopapular rashes, involving truncal, involving the neck. So this is the only part that is exposed. But we can still check up and see if there are some corrections regarding what I said. And thank you very much.
Stop it.
Hello, Dr. Tanimo, are you done with your contribution?
Yes, sir. Yes,
Okay.
sir.
All right. Is there any other? Thank you very much, Dr. Tanimo, for the contribution. So, any other contributions? Okay. As Dr. Tanimo has described, so it's a confluence of erythematous macular rashes, and then we can see some blisterings also. So, and also extending to the trunk, the arm, and the neck of this patient. And sorry, I want to reduce the font size on my phone. Okay, so so that's the description of the lesion, and usually is an immune-mediated kind of lesion, reaction to most likely nevirapine. So it's a type 3 hypersensitivity reaction. What other findings will you look for? You check the mucous membranes, even though from the question they say the mucous membranes are spared. Then you also want to look for target lesions if there are. You want to check for Nikolsky sign if there are. Also, you want, what's wrong with the combination? I think Dr. Tanimo has mentioned that. Okay, so that's not a combination. And how should the patient concern have been addressed? The patient should have, you will need to confirm we need to get details of the patient she's exposed to. You want to know, you want to confirm the retroviral status of that patient. You want to check the viral load, the CD4 count of that patient. Okay, just to know if, and then of course the level of exposure of is it a needle prick, is it patient having an open injury, or during surgery, is it a splash? So you want to also rule out those the contact, how this patient had contact with the retroviral disease patient. And also the patient also needs to also do a retroviral screening before, if it is established that she has an adequate exposure, then you prescribe a PEP, the appropriate PEP for at least the investigation you will do for the patient. Basically, skin biopsy. So you want to do a skin biopsy, do a histology where you could see if it's a toxic epidermal necrolysis, you might see epidermal necrosis. You can see mononuclear cells. Then Other investigations are just supportive investigations, just to, check for the extent of the problem and then complications of the problem. We want to do a food blood count, or to do a clotting profile. You want to do a renal function. You want to do a liver function test. Then what will you do to approach in treating this patient? First is to stop the offending agent, and then you want to also, part of the investigation is also for you to estimate, the body surface area, so as to know, are we dealing with a Stevens-Johnson syndrome, or are we dealing with a toxic epidermal necrolysis? And so the treatment is basically supportive. So you want to give fluid resuscitation, you want to do wound care, you want to do, well, in some cases, you want to give pharmacotherapy, even though pharmacotherapy has not been proven to be effective, and then you remove the offending agents. So I don't know if there's any other contribution, and then even a part of the investigations to want to do a wound swab MCS also to check if there's any offending organism causing it, or if there's any superimposed bacterial infection on the skin lesions. So I don't know, is there any other contribution, or I'll go to the chat box because the time is well spent.
Hello, Dr. Atta, for want of time, 753. So let me just come in and find you. I said, for want of time, can you hear me?
Yes, I can hear you.
Okay, hope it's clear.
Yes, I can hear you.
Okay.
I can hear you.
So for want of time, 754, I'll be fine, 753. Let me just fine-tune something so that we'll end close the class. The investigations, I think, this is the essence of this class. See, after all the speakers have spoken, you still answer the question. It's a discussion, so I must appreciate all that have spoken already. So for the investigations, remember, this patient that had this issue, you did well. Yes, I think there's something. How would you have addressed the concern of the patient? Someone that was exposed to an SYZ patient should not be attended to in the pharmacy in the first place. Patient should be sent to the hospital for screening. As you said, the partner should be screened, but the patient also should be screened. The partner should be screened for other STDs too. So the patient should also be screened. So the patient should be screened for all the STDs, syphilis, Hep B, Hep C. Those are the common ones, and other things. And this patient too, we need to do serum electrolyte urea creatinine is important. I think you mentioned it. The full blood count TSR, there might be leukocytosis, even if there is no infection. Because of if there is secondary bacterial infection, there will be neutrophilia, and the balance between the lymphocyte will be altered. But on a normal, if there is even no secondary bacterial infection, most of them also come down with leukocytosis. So when seen, should not be bothered because it's an inflammatory condition anyway. So the lymphocyte, the white blood cells number are increased because of the inflammatory conditions already ongoing. So when seen, might not indicate infection. Then the wound swab, usually prefer tissue swab. They give better result than wound swab MCS. So you mentioned skin tissue culture sensitivity, microscopic culture and sensitivity. Then the biopsy you mentioned, which is very important. Then the management, you did a good job. You tried, was a fair attempt. You stopped the offending agent. Such patients should be managed depending on the extent of the condition, but most time, high dependency unit. The room should be humid because now we've lost some of their skin, so they're exposed to the harsh environment. You know, the skin protects us from a lot of external factors. So now the skin barrier has been altered, so that protection is no more there. So such persons should be managed in high density high density room, then also reverse barrier nursing and barrier nursing in combination, minimize how you touch them. They should also minimize touching other people to avoid transmission of infections to the patient. Then the room should be humid. Now, if they lost their skin, so they're losing fluids, transepidermal water loss is increased. So you want to make sure the room is humid to minimize this. Then fluid input output. Such patients have to be well hydrated because they're losing a lot of fluid. And if this is not taken care of properly, you might go into AKI because of the excessive loss of fluid. So all these things have to come in place. Also, because they're loss of skin, the room should be warm, not cold, just a little warm to keep them more comfortable. Then feeding, we usually encourage high protein diet, especially animal-based, because now they're losing their lost skin. Skin is a protein, the keratin there's a keratin inside the skin and like a protein molecule. So as they're losing this, they're losing protein. So you want to replenish some of this protein they're losing. So most time also encourage that even the skin they're losing, it can be gathered daily and weighed. This will encourage to know their volume of protein to replace with. So if person have lost about 4 grams of protein that day, you cannot give anything less than that in supplementation of protein. That has to be at least the 4 grams the patient has lost. So all of this come into play. Then what my beautiful sister said about checking the mucous membrane, you check all of that. And if there is, they've already told you there's no oral anything, so the mucous membrane, the mouth is not affected. So what about the vagina? If it is, there's also another care you want to do. They want to make sure it's clean. You want to make sure that it's a patent. So sometimes we put dilators and sterile gauze just to keep it patent to avoid the synechia and adhesions later. Then you want to make sure the patient is breathing and there is no affectation of the airways. If it's affected, I think this will do. Then even if the oral cavities are not affected, sometimes these patients, because of they are sick, they might not want to, the oral care is reduced. So we really encourage antibacterial mouthwashes. So they use it morning, night, just to reduce the bacterial load in the mouth to encourage them and not to worsen their clinical state. Then you want to give them some supplements, antioxidants. Zinc is an antioxidant and also help in epithelial formation. So once you give them zinc, they re-epithelize quickly, the vitamin C, Then we usually do not encourage systemic antibiotics. I know you mentioned that we don't, except there are signs of systemic infection. If there are no signs of systemic infection, you just want to do as what we call you cover them up with sterile petrolatum jelly if it's available. If it's not available, just use your normal petrolatum jelly. A good example is our blue seal. Just use the blue seal, cover them, and as often as possible, usually say 2 to 3 hours, every 2 to 3 hours, it should be covered in this. Petrolatum jelly is occlusive, so it covers the skin completely, so nothing penetrates the skin, while it gives the skin time to heal naturally. So they are not prone to minimize infection, minimize trauma to the delicate skin that is already forming. Then if that localized infection, what we also do is give topical antibiotics like mupirocin cream. Then there are some others we use, but commonly we use mupirocin cream. So if you're asked this question in exam, the principle of management, remember, other comorbidities too should be addressed because the patient has Stevens Johnson, which can be a critical condition. Doesn't mean you should neglect the blood sugar. If the patient is diabetic, you want to take care of this because if not, the blood sugar for patient coming, we have other emergencies too. If patient is hypertensive, you want to take care of this. Patient already have a background CKD. So take care of this. If not, this condition will only see the patient, worsen the patient's clinical condition. So any comorbidities, you want to address it. So I think it's 8. I think we've been able to answer the question. If there are any questions, any comment, please let's quickly address it. Some of us have to go for money reviews and the rest. Any questions? Any comment from our teachers, participants?
Okay, there are some messages on the chat box. So basically, Dr. Tami is saying these medications are called that is the PEP. It's a combination of 3 drugs. You take them once or twice a day for 28 days. For adults, it's tenofovir and emcitabine, and the third tegravir. Okay, Dr. Momodu said never induced DRESS syndrome, or look for systemic affectation of the liver and fever. Dr. Afua say you cannot have Steven Johnson without mucosal involvement. At least 2 mucosal surfaces should be involved. And she said she thinks the diagnosis is erythema multiforme minor. Then Dr. Temida is saying can SJS occur without mucosal involvement. I think it's him in the same line.
Dr. Atta, let me quickly address some of this concern. Yes, SJS can occur without oral mucosal involvement. I think they wanted to pull that to just trick you guys. We know in West Africa, dermatology, they use dermatology, cardiology have joined them recently to ask bizarre questions. So expect anything from these 2 specialties. Actually, SJS can occur without oral involvement, without other mucosal involvement. So I don't know where you get your resources from. So, but that's the wrong one. That's the essence of this class, for us to share ideas. And so that's why we say encourage, please speak up, so that we know some of those things you are keeping inside of you that might not be true, so that we can actually correct some of these things. This particular question is actually a paper that was published. They brought this question from a paper that was published. So actually, this is SJS. So if you see this question in the exam, please go for SJS. Other diagnoses can come in as they're beautiful. They can come in as differentials, but this particular question is SJS. So know that SJS can occur without mucosa involvement in some cases. What they say, nothing is cast in stone. Anything can happen in medicine. Human body is dynamic. I see some strange cases. You say, no. You tell me this is not possible. Results will come. It's a pathology where results will come. Is that thing that is there. So nothing is cast on stone. So please, SJS can occur without mucosal involvement. So thank you. I don't know if we. Somebody brought us Scott 10. Scott 10 is actually for the 10 aspect of it. Please, participant, time has gone. Please take note of the Scott 10. It's very important. Just in case they repeat this question and instead of making it SJS, they make it toxic epidermal necrolysis, the brother of SJS. Just in case. So please go and know your Scott 10. It's very important because they might just ask you how would you score this patient in next exam. So please. So thank you, Dr. Ade, my beautiful sister, for bringing that one up. Thank you so much. I appreciate you, ma'am. So I don't know if there are any more comments. We need to close the class. In the absence of more comments, I want to appreciate our teachers, Chief Cookie, Chief Manza, Chief Bansi, Chief Chitu, Chief Remigus, my dear Adeyeye, Dr. Fatima, Dr. Kopi, Chief Yusuf, and all the other consultants present in this call. We appreciate your presence. Chief Cookie, ma. Chief Cookie, Chief Adeyeye, please, just address the class. Let's close, please. Adeyeye first, then Chief Cookie.
Good morning, everyone. Well done, my dear sister. So I want to say that we keep practicing, we keep getting better at it. It is possible to pass this exam at once. So I want to encourage you, just keep at what you're doing, keep reading, keep solving questions.